I'm Dr. Welch. I'm a medical oncologist in London, firstly, I find that bearing witness to people who are battling this awful disease called cancer, an absolutely rewarding experience, and playing a part in that struggle, I feel very privileged. But I got into this business with a certainty in my mind that we're going to get to a point where our treatments for cancer are much better and much easier. And the only way we're going to get to that is through studying cancer patients and cancer treatments through clinical trials. And that's why I'm passionate about it and happy to give a talk like this. So I do want to build a little bit as an overview of Clinical Trial 101, what is a cancer clinical trial, give you my take on why this is important, talk about a few myths about clinical trials, and then finish with just some comments on what the barriers are to patient participation and physician participation in clinical trials. So medical research in general takes it's a broad spectrum. Okay, I think when people think about medical research, we think about test tubes and petri dishes and mice, and that is important. That's over here, the basic science, and that is the discovery work that leads us to interventions, drugs, new kinds of radiation, new kinds of surgical techniques that we then take once we do a lot of work on that end. That's the bench. This is the bedside where it's patient-oriented research. This is what we're talking about with clinical trials, studying patients with newer treatments. I rate up here observational studies. These are equally important. Patients who have, many patients are participating in cancer research and don't know it. Because they participate in things like the Ontario Tumor Bank, where they are allowing people they are signing consent to have their tumor sample banked and parts of their medical condition, de-identified, not with any names or attached or anything like that. So that's all observational work, and that's equally important. What I am involved in is interventional work, so with new drugs, new ways of treating cancer. I think that's what most of us are dealing with or speaking about with clinical trials here at this, in this forum. And then once the clinical trials have been done and we've identified proven newer and better treatments, then they get out there and they're used as part of standard care. And it's important to study that as well, how we're using it, post-marketing research, make sure we're not missing any rare side effects. And I have some arrows here because it isn't a continuum all in one direction. Sometimes when we take a new intervention into clinical trials, we learn something about it that we then need to go back to the lab and understand it better and then take it back. And similar, when the clinical trials are done, we are treating this as standard treatment. We then learn more by doing the health outcomes research about how to use these things better. So it is a little bit of a back and forth. It's not just a continuum in one direction. Jan mentioned the phases of clinical trials, starting with very small studies to test. This is what they call phase 1. This is to prove that the drugs involved are safe, and they're very, very carefully monitored. Once they have a proven safety profile, then they're taken to a slightly larger group of patients to get a better sense of whether these interventions have some effectiveness, and then they're taken to larger studies to compare them to what the standard of care is. So a cancer clinical trial is a medical research study that people participate as volunteers to test new methods of prevention, screening, diagnosis, or treatment of cancer. I think that says it very well. So why are clinical trials important? Well, I'm not sure if you've heard the term evidence-based medicine, okay? That's what we practice in the Western society. Medical, or at least what medical doctors practice, based on medical evidence through clinical trials. That is how we get towards a standard treatment, because these treatments, every chemotherapy that we have, every the radiation treatments, well, chemotherapy and radiation treatments for certain, and new surgical interventions, say, we get to them as standard treatments because they have been studied in the past as clinical trials. So that's why it is important. Now, I'm not sure if you can see this, but not everything in life has to be verified by a clinical trial. What this says is, this is a joke article in one of the medical journals, British Journal, Medical Journal. You can see these are parachutes. It says, parachute used to prevent death related to gravitational challenge. So they point out that there has never been a randomized controlled trial to prove that a parachute will help to prevent injury if you're falling. But so a bit of a joke. Not everything has to be proven in a randomized controlled trial. We don't need a randomized controlled trial to, if you break your hip, there's never been a randomized controlled trial that says that operating on that and surgically fixing it helps you. That's not necessary. But a lot of, the cancer situation is certainly a different one, where, we certainly, and I'll get to that. So certainly clinical trials are out there, and there is a move to find better treatment. So here's two people having a conversation here. With this one saying, I just heard that there's drugs in clinical trials that might stop my cancer. Great, are you going to volunteer to participate for the trial? Of course not. Why would I do that? I wouldn't either. Sure hope they get some results soon. Okay, so I hope you're seeing that there's some disconnect there, right? Somebody has to do it. Why not me? Okay. So what should motivate you to be involved in clinical trials? I put him up there, Terry Fox. Okay. I could have put any picture of any loved ones that I have loved ones with cancer, patients with cancer. I think that it's that very. But Terry Fox is clearly a symbol for. He was running for cancer research for a better future. And I think that should be a motivation enough. This is a statistics about cancer. Okay, so I'm not sure how well this projects, but this is cancer incidence amongst males and females in different age groups. And you can see over time, this is 1983, this is 2012, death from cancer has slowly improved overall. This is rate per 100,000 compared to 1983 and 2012. There are 10 million more people in cancer, so there are more cancer deaths now than there were in 1983, but percentage-wise, slight improvement. This isn't good enough. There's too many people with cancer and dying from cancer. Cancer sucks. We need it. We need to strive for better. And I hope to impart on you that the way to do that is by participating in clinical trials. I do say that I am going to talk about the barriers of participation in clinical trials towards the end. But I think that, in my experience, I think there is clearly benefit for patients who are participating in cancer clinical trials, people participating in cancer clinical trials. Some of the work that I'm really interested in is experimental therapeutics. So these are the new cutting-edge drugs that will not get to market for, if ever, for a long, long time. Participation in clinical trials gives early access to these cutting-edge drugs or procedures. I think that there is some empowerment for patients, even patients who have the advanced disease, that their contribution to the overall knowledge and progress, I think that that's empowering to some patients, not for everybody, but I think that it can be an empowering experience. And there is data that suggests that medical care in centers and hospitals that participate in clinical trials is better than in those that don't. And I think it's a fair consensus across disciplines in medicine. So, at our institution, when you participate in a clinical trial, there's a whole group of other people that get involved in your care, not just the doctors and nurses, but the research staff, and so and you're followed with rigorous protocols. So I think that you have a sense of more eyes on you, and I think that many would think that that's a better way to go. So I wanted to switch gears to really just highlight, this is my top 5 list of myths about cancer clinical trials. So myth number 1, it's a guinea pig. I don't want to be a guinea pig. And you know, I think that when we talk about medical research, I'm not sure if anyone has heard of the Tuskegee experiment. Has anyone heard about that? So basically, that was in the 1950s. This was an experiment run by you know, before the age of, you know, ethics oversight and things like that. Where there was a black population in the southern United States intentionally inoculated with syphilis and those people thought that they were getting medical care. But the intention was to follow the natural history of syphilis. That's clearly bad. They were guinea pigs. Cancer clinical trials are not that. The big difference is that the intention of involvement in the clinical trial is benefit to you as an individual in terms of you know, specifically for the treatment trials. I'm trying to think of how that fits in with the you know, a prevention trial or something like that. That's certainly the intention is to prevent a cancer in a high-risk population. So I think the intention is the main difference. So that's how I explain away the sort of the guinea pig myth. Second myth. You know, these treatments are unproven. Okay, yeah, that's what snake oil captures. Okay, so unproven treatments. I want proven treatment. I think what I want to suggest to you, you know, especially in the advanced setting of cancer, if we had proven treatment that took the disease away, we'd be using it. We have good treatments, but we need better, and so. That's why we need to continue to strive. The unproven treatment aspect, clinical trials are very tightly regulated. As Jan was mentioning, you know, they have these roadmaps, these protocols where you know, it's really highly regulated to ensure patient safety. I find it interesting that so many cancer patients will gravitate towards unproven treatment that's billed as proven treatment, alternative therapies and things like that, some of which may have some merit, some of which I can tell you right now is snake oil, but will not gravitate towards participation in something novel that we are trying to prove it through a clinical trial. Yes, unproven at that point, but the path to proving it is through, you know, rigorous testing, using the scientific method as was alluded to before, that we all learned in biology class. So that's one myth. I think another myth is that clinical trials add cost to the overall healthcare system. In fact, if you actually do the math on this, if anything, clinical trials involvement in clinical trials actually can save the healthcare system some money. At the very least, it's a cost-neutral enterprise. Okay, so myth 4 has to do with the involvement of the doctor here. So this is a picture of a doctor. I hope your oncologist doesn't look like this guy. I think the myth here is that the oncologist or the doctor is going to be the one that is telling you about the clinical trial all the time. Some will, some won't. Clinical trials may be available, but due to time restraints, willingness of the doctor, they may not be apprising you of the availability of the clinical trial, not necessarily because they don't agree with it, but because they don't have the time to talk to you about it. I think we're in an age right now different from when this guy was maybe more my age, that there's in medicine there's much more of a focus on it's much more patient centered, and I think patients are driving the agenda. Patients are learning more on their own about their own health, and I think that we're really in a situation where it is not at all a bad thing from a physician standpoint for the patient to be asking questions, for patients to be asking about the availability of clinical trial. The fifth myth has to do with a placebo. You know, I don't want the placebo, right? And I can understand that. And I think that we very rarely use placebos in cancer trials. It's usually one treatment versus another. I can see a role for a placebo if the standard thing to do is nothing. If the standard thing to do is nothing, then, or if there's no effective treatment, then maybe a placebo might be, and not all clinical trials involve placebos. I think that's an important myth to dispel. Not all clinical trials actually do involve a placebo. Many of them, actually most of them don't. Most of them are one treatment versus another, or all patients getting a certain kind of treatment. Where I have been involved in placebo-controlled trials, it has been in a situation where we know what the best available treatment is, but maybe if we add something to that best available treatment, it will do better. So in that circumstance, we can add, to know whether that additional drug does some good and prove it, then we have two choices. We can either just give one group this additional drug and one group not give it to them. The trouble there is that if you know that you're getting something additionally, there is this thing called the placebo effect, meaning that if you think that you're getting something, you know, your system can trick you into something good happening. So this is why they have this placebo to compare to. Now, I think from a patient standpoint, obviously you don't want to be in the arm that is the standard, you know. But I think that when I counsel patients about participating in trials like that, it's less about the drug itself. It's about being involved in the process that gets us to a better understanding on how to treat the disease or treat the cancer. And so here's a little cartoon that says, you know, here's this drug trial. The trial shows that the new drug performs no better than placebo. Maybe we should invest in placebo. So barriers to clinical trial enrollment, I'll end on this just very quickly. This is showing, these are cancer centers across Ontario. And it's a little bit older information here, but this is the percentage of patients who participated in clinical trials across the board. London is over here. We're actually not doing too badly. This is the Princess Margaret Hospital. They're set up a little bit differently, so their clinical trial enrollment is higher. But you can see it's actually a minority of patients that actually participate in clinical trials. I think it should be higher than this. Clearly, we can't study every patient as part of a clinical trial, but I do think that, and these numbers are fairly consistent, actually probably a little better than what is, if you compare the American data. I think that it's more like 4% of patients with cancer are on cancer clinical trials. So from a patient's perspective, I think one of the barriers is clearly just not knowing that they're there, not knowing how important they are, and not having the not being told where they are or whether they are right for them. I think that this is a big barrier to clinical trial enrollment from a patient standpoint that needs to be addressed. I think the whole process of clinical trials, I'm not sure if anyone here has been approached about a clinical trial at all. It really starts with an informed consent document, which in cancer is this tome of a document that when you're overwhelmed by all of these patients in clinic and you get this 25-page document with big long words in it, I can only imagine how difficult that is to absorb. It's a part of the informed consent process, but it's not everything. And I think the bigger part of the informed consent process is talking to the physician, talking to the research coordinator about it. But the complexity of it all and wrapping your head around it when you're at a very vulnerable point and a very stressful point, if we could make this less complex, I think that would be better. You commented on this. I think participation in clinical trials, when you have a lot of other things to do, that's more effort. There's more clinic visits involved. You have to go for more tests. It's more. I'm suggesting to you that it's worth it in the grand scheme of things. Study design eligibility criteria. I think a big reason why the percentage is low is that many of these clinical trials have very strict criteria. You can only be this type of person, this kind of cancer, your kidney function has to be so, your liver, it's very strict eligibility criteria, and the study designs aren't necessarily conducive to enrolling everybody onto a clinical trial. So there isn't necessarily a clinical trial for everyone. I think that there are cultural language barriers. I hope that this one, this mistrust, I think as we educate a little bit more about how clinical trials are, hopefully that will become less of a barrier. There are barriers for the physician, though, too. Just as there is more time and effort required for the patient, I'll tell you, there is a lot more time and effort required of the physician, too. And we don't incentivize that in any way at our place. There's also lack of awareness amongst clinicians. I think that many clinicians assume that patients are not interested. Many clinicians believe that the standard therapy is best for the patient. I think that many patients will believe that the standard therapy is the best option too. And it really depends on the scenario. I think that there are certain situations in cancer treatment where treatment that we have is pretty good, and you wouldn't necessarily want to deviate from that. But unfortunately, that is the exception rather than the rule. And so I think that the resources devoted to clinical trials, we don't have enough of them, and we don't have as many clinical trials. A lot of that has to do with the cost of running these clinical trials, so we have to put limits on how many clinical trials we have available. So I hope that gave an overview of the issue of clinical trials. I'm happy to answer questions. I'm not sure if we should do that now or after the interview with John, but I'll open it to any questions that you might have. The question had to do with can you be on chemotherapy and on a clinical trial? I think it really depends on the clinical trial. If you're on chemotherapy for a certain cancer, that clinical trial may be a clinical trial of chemotherapy, so that you are comparing chemotherapy and the addition of something else, or one chemotherapy to another chemotherapy, or some supportive care measure along with chemotherapy. So it really depends on the situation. In the perfect world, there would be a clinical trial for absolutely every situation so that we can learn more about how to treat this disease better. So I hope that answers that question.
Yes.
So let me just make sure I got the question right. So I think it's not uncommon for patients who have an advanced cancer that we use the best available treatments. And we actually have an obligation, through regulation and things like that, to only use treatments that have some level of evidence to back them up. So we don't necessarily just take this drug off the shelf and this one and mix them together and see what happens. That's like an experiment, right? And it should not be, I guess, you talk about the idea of experiment. In somebody that has an advanced cancer, you're trying them on a treatment. You don't know whether that treatment is going to work or not until you try it. So in a way that I suppose that is, that's why they call in my world, what I have is a practice. Doctors have a practice. That doesn't sound very reassuring at all, but that's but we do use the tools that we have to the best of our ability. I think that it would be wrong to use an unapproved therapy outside of a clinical trial.